Hi, welcome everyone to the first CPCRN learning series of the year, the Canadian Primary Care Research Network. So in broad strokes, I'm going to complete a landing acknowledgement today to start the session off. Then we're going to start also discussing, we'll describe the overall format of the session, and then I will introduce the first presenter. So the CPCRN acknowledges the contributions that First Nations, Inuit, and Métis peoples have made for advancements in what we now call Canada. We respect the treaties that were made on these territories and lands. We acknowledge the harms of the past and present, and we dedicate ourselves to work with and listen to First Nations, Inuit, and Métis communities in the spirit of reconciliation and partnership. I myself acknowledge that the place in which I work and live is situated within the traditional unceded lands of the Kanien'kehá:ka peoples. There is also a strong historic presence of Anishinaabe peoples in what is now known as the Greater Montreal area. Tiohtià:ke, or Montreal, has also been and continues to be a gathering place for many First Nations from all directions. We honor and thank the traditional custodians of this land and strive to work for the success of future generations. So we also highly encourage you to think of your respective land acknowledgements and feel free to put them in the chat. We do encourage that. And so in terms of the session today, we'll be learning more about the Learning Health System Readiness tool. And we're very happy with the interest in this particular topic and session. So we've also decided to change the format a bit. Instead of a webinar format, it is a Zoom meeting to encourage and to facilitate engagement with everyone to feel more included. So that's an important change. Many of our sessions going forward will also be in this format as well. There will be a 30-minute presentation followed by a 30-minute question and answer / discussion section of this session. We are starting a little late today, so I think hopefully we can go a little bit later as well. Generally, it's about an hour, but it took a while for everyone to get into the session today. So without further ado, I introduce Dr. Sarah Ahmed to start the presentation today. Thanks very much.
Thank you, Jamie. So just wait for the slides. Thank you, everybody, for joining us today. We're looking forward to sharing the follow-up of some of the discussions we had, I guess, about a year ago about the development of a readiness measure to evaluate readiness for a learning health system. This work is based on, it's informed by a project that we started with the Quebec Support Unit here in Quebec. And it was initiated with the support of a large team. So we're representing the team, Dr. Hervé Zamahoun, others like Pascaline, Dr. Maria Poitras, and Dr. Yves Couturier, all informed the development of this tool over time. It's taken us some time to get to this stage. We recognized the vast amount of information that needs to be brought together to really get at the different components of a learning health system. And today we would like to delve into more detail with you around some of the areas that we're measuring in the tool and get some of your feedback. So I'm glad, as Jamie said, that we have the opportunity today to have more of an interactive session. This project is informed a lot by several of the initiatives as well that we've been working on over the past several years around working with different teams and health regions to integrate best practices around person-centered care and thinking through what information do we need in order to help to make decisions about what to prioritize in terms of working on to improve person-centered care? And then how do we evaluate what we're doing and make iterative changes and improvements over time? You can go to the next slide, Catherine. So I'm very happy to have Catherine and Joni with us today to help with the presentation and contribute to the discussions. Myself, I'm at McGill University with an affiliation with the Quebec Support Unit, as well as with the MUHC and the CREER, which is the Center for Rehabilitation Research. So a lot of my work is really in looking at integrated rehabilitation care across transitions. And for me, that's really what's shaped my thinking as a physical therapist and health services researcher. You can keep going, Catherine. So these are the objectives today, which is to recap some of the components and fundamentals of a learning health system, look at what is really needed in order to effectively implement and work towards a learning health system as an organization and a community, and then talk, and this is where Joni will really help facilitate the discussion with us today around patient engagement and community partnerships for supporting a learning health system. This is a definition of a learning health system. There have been a few, but many of them essentially talk about bringing together science, digital health and informatics, the commitment of a community of people around with the scientific evidence, and a shift in culture to continuously evaluate and learn and make improvements in order to work towards improving patient-centered care. One of the drivers for this is a recognition that we're having higher and higher demands, of course, around the needs of the population. We're having advances in medical care, which is wonderful, but also that means we're living longer and the needs of the population is changing over time. And so the question is, how could we learn from the everyday encounters and the everyday experiences of patients in order to make improvements over time and not wait for expensive clinical trials in order to decide which interventions work or don't. And we know that from previous experience, the traditional way of waiting for research to be done and then integrated to change practice takes a number of years. So the idea of the learning health system is to set in place the infrastructure, the culture, in order to rapidly do this together. And we'll talk about what those components are. I just wanted to make a comment that one of the things that distinguish a learning health system as defined by Dr. Charles Friedman from a quality improvement initiatives, and you can see it in the cycle here, is he had identified 3 things that really distinguish a learning health system. And those 3 things were a collaborative group working together continuously. So this idea that there's a committed team and that the team members more or less stay the same through the different cycles so that they're committed to seeing the changes happen and implement. The other was the idea of living with uncertainty. So the idea that, you know, we'll try things, we'll test them, we'll evaluate. We don't necessarily know which direction it will take us. But we're willing to learn and adapt and change as we go on. And then the third was a shared infrastructure. And so when we look at this here, what we're seeing, which is going from data to generating the knowledge of what needs to change or improve and what practices might help, to then putting in place those practices and evaluating it, it's having those 3 components working together throughout all of these cycles. And what's really important is that sort of thinking from the patient perspective, how are we going to integrate their voices, which, you know, other than administrative data, it's really important to have the PROMs and the PREMs included as well in this, and thinking about how do we support patients and families with the information and the skills they need in order to also be actively engaged in the care that's delivered and in the changes that are happening. There are exemplars of learning health systems across the different provinces in Canada. Certainly, we've learned a lot also from our colleagues across the UK, the US, and other areas. We'll share a couple of examples closer to home, and I'll turn it over to Catherine to talk a little bit about some of the local closer initiatives across Canada. And maybe, Catherine, you want to introduce yourself as well, because I didn't go into an in-depth introduction.
Yes, thank you so much. My name is Catherine Giroux, and I am a postdoctoral fellow working with Dr. Ahmed, Sarah. Before I dive into talking about what learning health systems currently look like in Canada, I'd like to introduce Joan, who's going to give an illustrative example of what the learning cycle looks like that Sarah was just talking about in rural Newfoundland.
Hello, everyone. I'm Joni Cranston. I'm actually a physiotherapist living and working in rural Newfoundland for the past 35 years. And I'm also the Newfoundland representative on the Pan-Canadian Patient Council of the CPCRN. I'm in British Columbia today. But in working on the coast on the Great Northern Peninsula of Newfoundland, I work in one community, and then there's a community a couple hours north, and those patients were finding it very difficult, neck and back pain patients, to travel 2 hours to see me in my clinic. And they kept saying, why can't you put a clinic in our community, a beautiful little spot called Portachois? So I said, okay, I started going down. I started working in a doctor's office, but the space wasn't ideal. I said to them, what I need is a space with a washer and dryer so I don't have to wash 10 loads of clothes. So they said, we have a space. The community had a space. The community lent, the council lent us the money to buy this beautiful heritage building on the waterfront. And we did some fundraising, performed minor renovations, and I started working there. We also attracted a full-time massage therapist. So the community asked for something. I said, I'll see what I can do. The community gave me something to help me achieve this. And now we've got something that's been up and running since April 2022. And when we talk to patients about the difference that's made in their life, it's huge that they don't have to travel 2 hours each way, 2 hours or more to access therapy. They also then said that they wanted access to healthy food. So we have a community kitchen established. And they also want access to exercise. So I'm currently writing grant proposals on trying to get exercise equipment to establish a fitness center. And they also want a nurse practitioner, maybe a doctor, and a few other things. So they are asking, we are giving it to them using community development principles. I think that is a very underlying theme in learning health systems. We can learn from community development principles.
Thank you so much. And building on what you were just explaining, there are a couple of examples of existing learning health systems in the literature in Canada. When we think of learning health systems, we often think about what's been done in the US, but our team has been working on an integrative review, which is still in progress, helping to identify what are the key elements of a learning health system. And here I'll present two very quick examples of existing learning health systems. One in Ontario, the Alliance for Healthier Communities Learning Health System, and one in Alberta, focused around the strategic clinical networks. And kind of the key elements that they highlight that really lead towards the successful implementation and uptake of a learning health system. So in both of these examples, they use existing networks or collaborative structures. So either strategic clinical networks or Ontario health teams as an example. They take a collaborative co-design approach to establish priorities, for example, with patient and family advisory councils. They use an iterative process for introducing change, like Alberta's innovation pipeline. They take a common data infrastructure, like electronic health records, using a real-time data warehouse. They have a capacity to analyze and share data or findings using dashboards or portals so that everybody has access to the information to make decisions. They have a capacity to measure return on investment, for example, with Alberta's improvement calculator, and communicate that value to potential adopters using knowledge mobilization strategies. And they also have additional funding to support the spread, scale, and sustainability of innovations that hold potential. But we're really interested in knowing how organizations are ready to implement a learning health system. So our team has been focused on developing a tool that can help organizations evaluate their readiness. And I'll have a few slides talking about the process of developing the tool, but we're really focused on what are interested parties' needs and priorities. How should data be collected and analyzed? Who can help move this data into clinical practice? And what governance, legal, privacy, and other structures do we already have in place? And thinking about these things can help to evaluate organizational readiness. So I'll pass it back to Sarah to talk a little bit about the evolution of the tool.
Thank you, Catherine. So when we first started this, we really, thought we'd get to the tool much faster than where we are right now. We're happy that we're at a stage where we've gotten enough feedback that we've simplified it drastically. But where we started off is with 4 domains, 25 subdomains within those, and those are touching on the areas that Catherine presented in the previous slide, with over 148 items. So you can see anything that requires that much time to evaluate won't be readily integrated into being able to measure organizational readiness. So we've spent a lot of time going back to colleagues to ask them to review the measure, to try to simplify it, and more recently have been able to do that with a family medicine group with Dr. Antoine Roux, Dr. Catherine Bouffard, and Ms. Sophie Bois, who have been extremely helpful in helping us think through how can we simplify the measure. And that's where we're at now and ready finally to start the Delphi process. Just to give you an idea of how those 4 broader areas have translated into more subdomains. So the 4 broad areas are looking at where the performance is right now, what is prioritized. And Catherine talked about some of the common features across learning health systems about how they prioritize and what helps to reach success in terms of making changes. So these are the domains that fall under performance to data, which is prioritization, thinking through what needs to be measured and how is that data going to be collected. There's the data to knowledge, so going all the way from capturing the data to translating it into a meaningful way that could be acted on. And then implementation of the changes that need to happen through knowledge to performance. And then, of course, we know that there are core values that are not often directly measured that really do often influence success of groups of people working together in general in organizations. And so there are things like the values around governance, whether care is driven around what individuals' needs are, is it person-focused, leadership, and of course, thinking through issues of equity. Will we be able to address the needs of a diverse group of people in the way that data is being collected and the way that new practices are being implemented? And then there, of course, the areas around legal, privacy, and other areas that we are also trying to capture through the readiness for a learning health system measure. So we're going to move into an exercise of getting your feedback, and I hope this is where we can have some interactivity. So I'll turn it back to you, Catherine.
That's right. So at this point, we're interested to know more about your thoughts about our current measure as it stands. So we have a couple examples of items, and I'll display them on the screen, but we're really interested to know if the items are clear to you, if they're representative for your contexts, if they're relevant for your settings. And we recognize that you represent a diverse group of interested parties. So you might be patients, you might be decision makers, you might be healthcare professionals, you might be researchers, policymakers. So we're really interested in your broad perspectives on the items that we're about to present, whether the wording is clear, whether the meanings might have multiple meanings for you. Just any feedback that you have, we're interested in it. So we'll invite you to raise your hands or unmute or whatever is most appropriate to our moderators of this session. So firstly, From our first domain, we have defining outcome and indicator measures. The first the item that we have on the screen is, my organization has a quality improvement committee that can objectively determine relevant outcomes or indicators for a given health problem. Is this clear, representative, relevant?
Laura, I see your hand up. Feel free to unmute yourself and provide some feedback. Thank you.
Hi, thank you so much. My name's Lara McLaughlin, and I work in BC at Island Health on learning health systems. And my question about this particular domain relates to defining problems. So before we focus on defining outcome and indicator measures, what infrastructure do we have in place to define the problem, and how do we make our quality improvement tools and change management methodology sort of surface what the problem of interest for the learning health system should be? I think of that as like a very important first step and want to understand how that connects.
Thanks, Laura. So I don't know, Sarah, did you want to begin by answering that question?
Yeah, thanks, Laura, for that question. And I think that's really important. I wish we had time to go through all of the items in the questionnaire, because we would have started with what are your priorities. So maybe you want to go one step back. So we did selectively pick a couple of items, but you're right, Laura, based on your question, I recognize that it sounds like we're starting from measuring before we know what we're measuring or why we're measuring. But if you go back, Catherine, a couple of slides to our framework, that's really what the measurement tool would start with a question around, does the organization or the clinic have the resources or the process in order to prioritize important questions that are relevant to work on. So that's where it would start. And I think that's the question that you're asking, correct? Is before thinking about outcomes, is thinking up through how priority areas are prioritized to target.
Precisely, yeah. What we find is that we have like a plethora of tools to surface areas for improvement in practice. And the challenge is really around like, what is the process for defining which tool is the most relevant for defining the problems for learning health systems, or how do we make the tools work together in a meaningful way to do that? So we really are like, I'm thinking a lot on that question right now. And
Thank you. I'm going to see what Joni has to say, and then I have a question for you, Laura, after, but I'll let Joni go ahead.
I think quickly the answer to that question is involve patients from the start. Have a patient council that you can go back to, because we as a health system, we try to define problems, but what really matters is what matters to the patient. So if you have a group of patients that you can bounce things off, I think that they will keep you on track very well.
Thanks, Joni. And that is important. And that's what I think Catherine had pulled out and mentioned across the other learning health systems, is that when they really had a patient-centered approach to prioritize the areas. And the example you gave us actually about the community coming together was driven by that. So, but you had mentioned tools, and I was wondering what you're thinking of when you refer to tools for identifying problems.
yeah, and it really plays into the comment from the patient partner who just spoke. So yeah, we've done like an extensive research project on patient and caregiver experience in our program. That's working, one of them that's working on learning health systems, which is hospital at home, and it's published research on patient and caregiver experience. We also have data on patient and caregiver experience from other surveys within the hospital. We've designed shorter surveys to understand patient and caregiver experience. We have staff feedback on priorities that come up, and we gather that through PSLS. We gather that through safety huddles. We gather that through like an improvement board. So, and we also have data like from our Cerner and EMR systems on the program, and we have DAD data that we look at that is about like the sort of clinical outcomes related to patients who are part of the program. So there's just a lot. And so all this work around figuring out what the priorities are, what the problems are, requires like a quite a sophisticated dive into data as the beginning of this learning health system, I think. And yeah, just more examples of how to do that, I feel is a need.
Okay, that's helpful for us. And we find what we found in trying to simplify the measure is this question of, because you're getting right to the solutions, right, Laura? And what we're finding is a lot of people who give us feedback, rightfully so, they go to the solutions because everyone wants to sort of think,
No,
no,
this is just the problems. I'm just talking about
the
the
problems. Okay.
not the solutions yet, like before creating a learning community, right? Just uncovering what the priorities are for improvement
So
or defining problem.
Okay. So tools to support that process of prioritization using all of that information that you just.
I think so. I think so. Yeah.
Okay. So that's important for us to keep in mind in how we ask about that first question. And I wondered, Catherine, if you go back to the item that you showed, is part of that is the data that's being collected to identify the priorities relevant. So what is the most important data, and how do you prioritize that data in order to decide what the priorities are? Because if you have multiple sources, is what I'm hearing you say, how do you put that all together in order to decide what the priorities are and what might be a process for that? Does anybody else have comments on this question specifically, but defining the outcome and indicator measures? So Catherine, maybe we can go on to the next one and have some discussion around that.
Sounds good. So jumping ahead, a couple domains, or one domain, but a couple items. Domain 2.3 is about result interpretation. And one of the items under this domain reads, my organization has a qualified team, including main stakeholders, who can interpret, exchange, and prioritize data results and formulate relevant recommendations for continuous quality improvement. Is this item clear, representative, and relevant to you, whoever you are, wherever you work?
So to everyone, feel free to also type in the chat if you feel more comfortable with that. I will read them out as we go along. And I see Sabrina's hand up. So do you have any feedback for us, Sabrina?
Hi, my name is Sabrina Wong. I'm located in Vancouver on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people at the University of British Columbia. And so I just wanted to say, I feel like there's a lot of stuff going on in the interpret, exchange, and prioritize results. So that's a lot to put into the domain, and potentially maybe you have different items under each of those different items of interpret, exchange, and prioritize, but there's oftentimes different people or whatever that are maybe potentially working on those kinds of things, and then different people who may then formulate the relevant recommendation. So it would be great. I think that maybe works for a small organization, and I'm thinking like a single primary care practice. But for larger organizations such as like a health authority, et cetera, that may be complicated in terms of the domain. Thank you.
Thank you, Sabrina. Yeah.
Thanks, Sabrina. Jennifer, related somewhat into this domain 2.3 result interpretation item, I believe she has a question, does it have to be a formal QI team in the chat? And Jenna, as a follow-up, I feel that the organization having a QI committee is important, but that committee also needs to be prioritized by executive sponsors, not sure where they may fit. And then Patty, of course, as a follow-up to that, I don't think qualified team is clear. Will that term be defined for people before they come to this item? So I don't know if you have any, if you want to, Sarah, do you want to start with that, or Catherine?
Catherine, do you want to go ahead and give your thoughts and then I can add?
I definitely agree with the feedback that's being given. I think that, well, I certainly agree that there is a lot going on and it could be simplified in terms of the number of items or what we're asking in the item. So asking about a qualified team or asking about who can interpret, etc. I'm just trying to read the chat as we're going, so I'll actually let Sarah speak as I take notes.
Sure. And so that's a good question about, do we need a formal quality improvement team? I think like anything, and I think this was the comment that was made after, there needs to be designated team of people or individuals who are and, you know, given the resources and the time to do this work around thinking through the cycle of prioritizing and thinking about the measurement and so on. So does it have to be called a quality improvement team? I don't know, but I think having a designated person or team of people is key and important in defining the process. And this is one of the common features we found across Learning Health System, is that there was a team that sort of coached, whether it was a large organization that coached the smaller programs or a smaller organization, at least there was one individual or person who was designated as taking on that role. So I don't know if that answers the question, but if anyone else has other thoughts or experiences of how it works in your organization, I think that's the most important thing, is designating people to take that on and define it as a formal process of the organization. Did we cover
Thanks,
everything,
Sarah.
Jamie?
There's
Yeah.
a lot of interesting commentary in the chat right now. So for example, Emily said that there are two elements to consider. One is having the team, and the other is actually having the structures and processes in place to leverage that team. Yeah, really talking about having that governance structure in place to make the team successful. Just trying to write down everybody's thoughts, but I imagine the chat is also being recorded.
Yeah, I think so. And that is, yeah, go ahead, Jamie.
And then, you know, Lara also mentions in the chat that they've had a lot of back and forth on whether the improvement team is formed before the problem is defined, or the improvement team comes first to define the problem. So something also to consider in this, and some other additional feedback here. As a follow-up, she meant that the team comes after the problem is defined, just to make that clear. So those are all the comments that we have in the chat. Any other sort of follow-up, anything to, and yes, Jen, seems like a chicken and egg issue. Yes, exactly. Any other comments that you want to build off of this? Joan?
Joan?
Principle of community development from the place model. E, engage both and thinking. It's the chicken and the egg. Sometimes it's the team that identifies the problem. Sometimes the problem is identified and a team comes around it. It can be either or, both and.
So for the interest of time, moving us along to the next domain for feedback, we've selected implementation evaluation, and the item that we're interested in your feedback on is, my organization is ready to promote the improvement of outcomes related to population health, patient care experiences, health professional team or manager experience, and cost. Is this item clear, representative, and relevant?
Anybody want to raise their hands to share some feedback on this item? Audrey Lesparence?
Hi, I'm based in Montreal. I'm at the School of Public Policy here in Montreal. Actually, the thing is, it's really relevant. It's the same with all the domains you just presented. I feel like there are many elements for me in here with population health, patient experience, and even manager experience and cost. It's just like a bundle of so many things that I'm not sure that I would be able to answer that question. And I guess you're going to ask that question to people that are sometimes in the middle of an organization where there's a lot of readiness in terms of, for instance, patient care experiences, but they don't necessarily have a really broader understanding of population health needs. And so I don't know, there are a lot of things in the same domain. And I'm wondering if it might actually create a bit of an unclear pattern for me, like if I'm just putting myself in a position of a participant to the Delphi.
So thank you for that. And yes, I this comes back to Sabrina's comment as well, that probably separating them out would be more make it easier for the person, whoever's answering this, to answer. For those of you familiar with the quintuple aim, what I see here that came out of the item that we pulled from existing questionnaires is that it was probably all, they just lumped all outcomes into one. And I guess the question to you, Audrey, is if it was just pulling out one outcome, would that be relevant? Like, should we separate it into population health, patient experiences, or?
I do think so. And I think that, like, even if it adds more items to your questionnaire, I think it's going to be easier to answer. So it's going to cut down on time. So if we just think about it like logistically, I think it's not a bad idea. But also because I'm just putting myself in the, like, I've done a Delphi with a lot of patient partners also, and like they can actually really have a constructed answer on each item, but as a whole, it becomes, almost like too lumpy to a certain extent, because it just speaks to different elements of their experience with that organization and that setting. So I really think that you're going to end up with maybe more questions, but it's going to be way more easy to answer. And it stays relevant, and I think it speaks to that quadruple or quintuple aim as well, even if there are separate in the answers.
Thank you.
Also, to build on this a bit, Mary did leave some comments in the chat. I think it would be helpful to have strategies attached to each domain to make it easier for people to action the domain. And mostly the domains are very general, high level, so implementation will vary depending on the type of organization and level, micro, meso, macro. And Patty agrees that separating them out to help when answering would be helpful. She agreed with that.
I have a question to Sarah and Catherine. What exactly are you trying to get? Like, what's your vision of whatever the domain is, implementation, evaluation? Because I think that would help to understand what it is that you're meaning to really try to simplify what you're going to then try to have in the Delphi process. So like everything has to be, we just did a Delphi process and everything has to really kind of be defined so that people are reading and understanding what it is that you're meaning. Because I'm not sure everybody would understand what implementation evaluation is, but then as Audrey was describing, there's a lot of stuff that's action packed in here. So what exactly were you trying to get at? Because I think that would be helpful.
Yeah, so and that is helpful to hear that feedback, Sabrina, because when we got feedback from sort of our very initial go at the questionnaire, we did define each of those domains of what do we mean by implementation evaluation. So it's clearly we have to put that back in to make it clear, even though we've maybe, and I think there's another thing that maybe when you see the items together as a whole, it makes it a bit clearer, but it's clear that we do need that definition, I think, to tie it all together and figure out what are we getting at in terms of implementation evaluation. But it is having that question specifically because of the word, I think it was commitment, Catherine, in the item, I can't remember what the word is really saying, do we agree as an organization that we want to work towards improving these outcomes? Are we committed to improving these outcomes? My organization is ready to promote and improve. So to what extent do you think your organization is ready to promote and improve? And there was another comment that Audrey made that made me wonder, these items were picked because if you can answer highly on all of them, you're at a very high level of readiness. That's the assumption. And so maybe the way they're worded is assuming already as a default, a very high level of readiness. And so and which is causing things, why we pack so many things in. And so I think this breaking it down is really important, like we discussed before. But yeah, I get your comments, Sabrina, and I think we do need to define it, implementation evaluation, that you're committed, and then the organization is committed and then has the resources in order to track what changes are being implemented as a way of improving whatever area was prioritized, and then feeding back that information to say, did we make the improvements we meant to make? And is it really improving our outcomes?
So again, just being mindful of time, we'll take Audrey as the last comment on this, and then I'll move the presentation along so that we can have an opportunity for a broader discussion, hopefully at the end.
It's a very, very small point. Because those concepts, because they are concepts, are very broad, people will attach their answer to something very tangible and specific. So I'm thinking patient experience that might also speak for some people on how is the organization, partnering with patients in some aspects of the work. And if they do, they will say yes on the readiness level. And for others, when they think about patient experience, it might just be about, experience with partnership at the level of care. And that's a very whole different thing. But if it does encompass, and those elements encompass so many other things, I would really isolate them, and that makes it easier also even for, I don't know if you'll have a qualitative like little space for people to comment on their answers, but they might give you a little idea about what they felt was, almost the elements of readiness they were thinking about when they answered. And I think that that's going to be really helpful in the results. So and I feel that this comment is not just for this particular domain, but all the things you just showed us.
Thank you so much. Thank you, everybody. We really appreciate all of your very thoughtful and valuable contributions and feedback to our items. And it's given us a lot to think about and consider as we go forward with refining our measure and bringing it forward to the Delphi process. So at this point, I would like to invite Joan to talk about meaningfully partnering with patients within a learning health system.
Yeah, thank you. And I must say that your definition of the learning health system is one of the best that I've come across, integrating the science and the informatics and including incentives and creating a culture. And I must say it's a lot easier to do in a small rural community than when you're trying to change a system in Montreal, Quebec, or Alberta. So I'm happy that I'm working where I am. One of the things that you said was learning from everyday encounters, and that's what we as clinicians do, our everyday encounters in our community or with our patients, and we take those ideas and then we bring them up to a higher level. And really incorporating health professional experience is really important because they have direct contact with patients, and then they know some of the best patients to connect with who can connect with others. It's about building the networks. So when I have certain of my patients in one of the first few visits, I'll say to them, are you willing to be one of my patient advisors or my patient partners? Because your experience is really relevant and representative. And I also know that you are connected with so many other people that I need to connect with. So in terms of engaging them, in any community development model, which is physiotherapist health model, also community development model, it's listen to what they have to say, come back often. Don't just ask them once, come back often. Bring them together in groups. There's many ways of gathering information, bringing them together in groups and providing them with not just a meal, a healthy meal, something that's good and healthy. They don't want to go to a health meeting and eat crap food. So good food, that's one of the incentives. In some of the grants that I use for my programming, we also are able to provide them with grocery gift cards. If they've come and spent a day in helping me evaluate a survey or participating in a workshop, we give them a grocery gift card to a local grocery store, not something in a big city far away. So it becomes a circular economy. It's a real incentive for them. It is also really tangibly thanking them for their participation. So incentives is really important. And that is what creates this culture where they know that somebody's actually listening to them and that their experience is meaningful. And then they are sometimes willing to make the changes in themselves and to facilitate changes in the community, which is where the system really needs to change. At the community level, systems don't change in the hospital. Systems change at the community level. That's how we can really impact people's health. So come back often, feed them well, listen to what they say. And so researchers and grad students are really the gold in here, as well as clinicians, because researchers and grad students can give the high level perspective and they have wonderful networks. And then the clinicians are the connection to the people on the ground and their communities. So that flow has worked really well for me with the work that I'm doing.
Excellent. Thank you so much. And then I'll pass it off to Sarah to talk a little bit about what's next, and then we'll open the floor for questions.
Thank you, Catherine, and thank you, Joan. I think that's really important, and it's making me reflect on how many questions do we have about the community in the measure, and maybe we don't have any, I don't remember, but we'll go back and check that and circle back to you to help us with that, because you're right. That's where we look at a lot of the learning health systems, they have strong ties into the community. So in terms of next steps, we're taking this feedback, other feedback that we're getting along the way, and then we'll finalize a draft of the Delphi. I think at some point we just have to be brave and put it out there, but definitely some of the basic comments like separating out ideas in an item that's covering multiple things, those types of decisions that we have to make, and we keep hoping after feedback that we'll get into a shorter version of the questionnaire, but it seems like we're getting sometimes into a longer version. We'll have to revisit that and see what we can do. Just in terms of the questionnaire itself, and there were some comments in the chat about a maturity model, which I like that idea. We hadn't quite called it that, but we thought of a modular approach where maybe there's a progression, a natural progression that organizations move through in some of these domains. And so could it, based on where they're starting, we minimize what they answer and then add on more as things progress? That's one way of thinking about it. So there will be two aspects to this. It's the actual content of the questionnaire, but then the process of implementation that we would come back and think through in each round of the Delphi. And then once we have feedback on what would look like a final set of items in the questionnaire to actually go into some of our settings, we'll start with the family medicine groups here in Quebec. That the support unit has helped us identify, and other colleagues that are working on learning health system projects throughout Quebec. And then come with a sort of close to final version of the questionnaire and disseminate it and continue the validation process where we work with different organizations that are perceived to be at different levels of readiness for a learning health system to see does our questionnaire perform the way we expect it to. But in parallel to this is we're also gathering tools. So some comments came out with strategies, like how do I take all of this data and put it together in order to identify what the priorities are? How do we assemble a quality improvement team? Or how would we get started if it's a small organization? So there are a lot of tools out there and others that might need to be developed that will have in a playbook that helps guide the evaluation, but also tools to help move along the readiness scale of a learning health system. So this is where the direction we're going in the next while. And the Delphi, we've committed to having a first version of the questionnaire by March this year. So it will come out sooner than later, and we might not get it right the first time around. That's what the Delphi is for. But we'll try to refine it and get closer to a version that's acceptable and will be useful as we move through the different iterations of the Delphi. So we will, through Jamie and the committee, to go reach out to you to participate and have your feedback, which has been great today. So thank you. I really appreciate the comments that have been made.
And I know there's not that much time left, but if you do have any questions or comments, please feel free to ask, or alternatively, be in touch by email. We'll be happy to share that as well.
And will we be able to use the slides to so that people could see the kind of work that you're doing? Is that possible? Okay, that would be great. We'll put that on our website. So yeah, that'd be great. Thank you.
Thank you, Sabrina. So I don't know, Jamie, do you want us to continue with questions if there are, or do we wrap up?
I don't see any. I see a lot of thank yous, etc. Just so everyone knows, this has been recorded today. It will be also included on our website, along with the PowerPoint presentation slides as resources. We're also, ideally, we will have deliverables that come from all of these sessions, as mentioned, and so we hope to build essentially a toolkit for practice-based research and learning networks. So the idea here would be that would also be an area of our website with some learnings from this session and future sessions as well. Please stay on and complete our evaluation at the end as well. So that should pop up. We're always in the process of improving our learning series. And the next session will be January 30th, so a week from today at noon, same time. This will be regarding lessons learned about engagement from the OECD Paris project. So this is a survey that we're validating and developing to collect PREMs and PROMs, patient-reported experience and outcome measures, in a more regular and systematic way. So there'll be discussion some of the lessons learned about how to engage with specifically primary care practices. So don't miss that either. Sabrina, I see your hand is up.
Yeah, no, that's great. Thanks. Yeah, it's really around engagement of practice-based research and learning networks. So this session really is helpful to talk about learning health system readiness and what does that look like. I was just going to make a quick comment to you that when you're doing your Delphi, you could consider doing a modified Delphi. I don't know if you're thinking about that, but so that you have the open-ended questions box so that you don't have to put everything into like, you know, rate this and how important do you think this is, but you could also have open-ended and analyze that. And we found that to be fairly successful just in terms of like trying to keep it short and have people complete.
That would be good. Yeah, I think, thanks, Sabrina, for that. We were just discussing that of how do we do it. And I think that's a great idea, given how complex this is and how new it is in the sense of trying to measure the readiness. So I think that's a great idea. We also played around with the idea of having interviews in between each round with some of the key people who responded, which helps to go even more in depth. But of course, that's a whole other amount of resources and time. So we'll see which one we do. But I think at a minimum, having the open-ended questions is a great idea.
The other thing that you might consider is modularizing it. So like having multiple Delphi processes going on. Because I saw that slide where it was like, okay, this is the knowledge to data. This is, you know, so you've had, so then therefore then some people are only answering some pieces of it, but you're getting more coverage. So that could also be a way to think about your Delphi, is that you could have a bunch of people, and then 5 people are doing the one module, and et cetera, and then the next time around, I guess they would continue to do it, and then you might think about, okay, would you be willing to do another 2 rounds, and then you would give those 5 people put them into a different group.
A good
so
idea.
I think there's ways you could, you know, think about having it shortened to meet your needs for people, as well as get the information that you need.
That would be, yeah, I think that's a great idea. And maybe the final version, getting everybody to rate it, I don't know, it depends how long it is. But yeah, I think that's a great way of splitting it up and making it feasible.
That's great. Jamie, I don't see the evaluation, but I guess it's there somewhere.
When you exit out of it, it should pop up for all of you. So please complete it.
Great,
And
okay.
yeah, I guess we'll let you go. It's a one minute over. Thanks again for your interest. Have a great day. Take care. Bye-bye.
Thank you. Thank you, Joni. Thanks, Jamie. So looking forward to following up where this goes.
Thank
We'll
you.
meet soon, Sarah. Sounds good.
Take care.
Take care.
Bye.
Bye-bye.
Bye.